So my name is David from one of the PGY4s in the Emerge program here, and I'd like to thank Dr. McCauley for his supervision and guidance through the preparation of these rounds. Today, we're going to be discussing a case of nausea and vomiting, and it's based on a case that I've seen in the Emerge department just a few months ago. It's something that we always see, we see very frequently in our Emerge department, nausea, vomiting, and gastric pain. And this was the most appealing photo of all the people. I searched, vomiting on Google Images, and a lot of, gross stuff out there. So I decided to go with something happy, relatively more known. So we're going to discuss a case. It's not actually him, but a 29-year-old male. I saw him in Victoria Hospital, Pod C, RAS, bed 3 or 4, and the triage note said, nausea, vomiting, abdo pain for about 3 days. Can't keep anything down, no blood, no chest pain, or shortness of breath. And why don't we ask one of our junior residents about the initial approach to seeing anybody in the emergency department with this presentation. So can I get a volunteer from our PGY1 core?
I'll take a stab.
So obviously I want to assess their vitals, make sure that their hemodynamic is stable, and take an ABC approach to this.
Perfect.
Once that's taken care of, get 2 hardcore IVs in case they need further aggressive fluid rehydration, and then start to work through etiologies for
Excellent. Thank you very much. So that's exactly our approach. Go through our ABCs. So he was maintaining well. He was maintaining his airway. For breathing circulation, we got a full set of vitals to assess what was going on. Let's ask one of your other PGY1 colleagues what they think of these set of vitals.
I'll ask Aaron Stone for the volunteer.
Thank you for volunteering, Dr. Stone.
So he's hypertensive. He's tachycardic. Blood pressure 1/65. I don't know what his baseline is, but seems to be maintaining blood pressure. And the rest of the vitals are normal.
Okay, so we mentioned a bit of.
It's his tachycardia.
Okay.
So early signs of body depletion.
Excellent.
Excellent.
Excellent. So yeah, I definitely agree that the most prominent feature here would be his tachycardia. We're not sure what the rhythm is, but that is something that we want to find out. And perhaps his blood pressure is on the lower side, not considered, I guess, hypotensive, but we'll see what his baseline is. So I gathered a bit of history from this gentleman. He said, I couldn't keep anything down. He says he's actually been vomiting for about 5 days, no diarrhea, and his PO intake was really limited to a few sips of water. He said he had some belly pain as well, mostly in the epigastrium. And I asked him, well, how many episodes of vomiting have you had? And he said, I stopped counting, it was way too much. But otherwise, he was previously well, so really not too many red flags that I could ascertain. No travel, no fever or chills, no headache, and no exposures to sick contact, strange foods, no swimming or well water exposure. And otherwise, he was a well 29-year-old male with no medical or surgical history and no routine medications. On the physical exam, he actually looked well, no acute distress, but he was clinically hypovolemic. So he had dry mucous membranes, he had sinus tachycardia, and his abdominal exam, he was a bit tender to his epigastrium, but didn't have any signs of peritonitis, no guarding or rebound. His GU exam was normal, his hernia, testicular exam was normal, and no costovertebral angle tenderness. That's what I drew on the chart, the little X on top of his belly button. Why don't we go to our PGY2 core to give us a good initial approach to perhaps treatment and investigation with a simultaneous approach to a patient who's symptomatic and feeling unwell. So, any volunteers?
So, as we mentioned, we've got IVs that was put in. So, it's start by ordering the year bolus, see if we can have a bit more rehydrated. We're still feeling nauseous, and some antiemetics.
Which antibiotic would you choose?
He's a young guy who's receiving no cardiac issues, so gravel or history was, but it doesn't sound like it was distended, but I figured you can see if there's anything obvious there.
Sure. Excellent. I think it's a very reasonable initial approach. So my kind of how I drive my investigations is through a few different angles. So first, I wanted to perhaps make a diagnosis. So I threw in a CDC diff, transaminases, lipase, alkalos GT, and hopefully that would give me an idea about, well, if he has a GI bleed, then maybe the CDC might be useful. The transaminases for hepatitis, cholecystitis picture, lipase for pancreatitis, and the biliary enzymes for any biliary pathology. And given his presentation, I also wanted to rule out any acute complications of this specific presentation. A person who hasn't been getting adequate fluid intake by mouth could have acute kidney injury, so I got creatinuria. Could have electrolyte abnormalities, hypokalemia, hyponatremia, so I got some electrolytes, and I was gonna get a BBG, but I actually didn't in this case for any metabolic abnormalities, most predominantly metabolic alkalosis, considering the amount of stomach acids he would be losing. And lastly, I thought, is there any serious conditions in this population that I should right away get a good handle on? So if it was a 29-year-old female, for sure we're going to get a beta HCG. If it was an older patient or a diabetic patient, maybe with a cardiac history, we want to think about getting an EKG right off the bat, plus or minus CK tropes in a higher risk clinical situation. So those are three ways that you can think about when you're ordering your investigations: making diagnosis, ruling out any complications of this presentation, and then any serious conditions that you want to be notified of right away. Now, a bit of a more kind of senior question: how would you organize your differential diagnosis for this presentation? Now, what are PGY-3s, CCFP or FRCP? Any volunteers? Dr. Shappert. Sorry.
Well, you're very able to put things in differential earlier investigation slides that you break down by systems, intervality, pancreatitis, hepatitis, cholecystitis. And then moving down to the sort of more distal GI tract, to answer the threat pathology, doesn't sound like that's the case necessarily at the lower or differential. We think it was toxicology for drug abuse cause, so the marijuana user, but that would also be a differential disease. The GIB, I'll be starting with these over here on GI.
Sure.
Quality of the
Okay. Anybody else, the non-GI causes that would be considered? You alluded to a bit of toxicological causes. Any other non-GI causes that we should consider in this case?
Central causes.
Sure. What do you mean by that?
So mass attack, head trauma right there. I wasn't sure, but it's a volume course in the mornings. Picking up associated with history of cancer for himself.
Okay. So actually, that's kind of thinking outside the GI tract. So central causes, toxicological causes, GI causes. I think that's a pretty good start. So why don't we go from there? The way I understand kind of any medical presentation is we want to understand the physiology first, and then use that to guide our kind of diagnostic approach. So I'm just going to harp a little bit on kind of the pathophysiology of clinical presentations. I think in Emerge we often practice by using what's tried and true, using pattern recognition, and using clinical experience, which is absolutely very valuable. But we should always remember our first principles that what we practice should be informed by the science. It should be informed by our knowledge of biology, physiology, and anatomy. And I think that is kind of what distinguishes us as physicians. So, first a bit about the anatomy of nausea and vomiting. I looked at this slide, it's from Netter's, and then I kind of wanted to vomit myself, so quickly moved on to more different anatomy slides. This is going going to be how I organize my understanding of nausea and vomiting. So the vomiting center of the brain is called the nucleus tractus solitarius, or the nucleus of the solitary tract. Now it's located in the medulla, all the way down there in the right corner. And it's a cluster of nuclei that's it's a crossroads for a few cranial nerves, the glossopharyngeal nerve, facial nerve, vagus nerve. And it's also the kind of sensor for all nausea stimuli throughout the body. It also is the source of information to create the rhythmic kind of motions that causes vomiting. So it's both kind of the inputs and the outputs, the afferent information and the efferent information. So, excellent. So this is a bit of the model for the neurologic framework by which nausea and vomiting happens. You get exogenous or endogenous stimuli that is received by the NTS, nucleus tractus solitarius, or what we're going to call the vomiting center, and that information gets carried on to a pattern generator. Now, the human body has several different pattern generators, and all it is a coordinated set of actions that your brain signals, and there's not much thought process to it. For example, taking a deep breath in, contracting your diaphragm, using your intercostal muscles, taking a breath in and exhaling. Swallowing. Swallowing there's several phases of swallowing, as you all know, oropharyngeal, esophageal, and all those coordinated actions must happen in a very sequential manner for it to succeed. Even walking is a pattern generator for that. So the pattern generator for vomiting involves three major areas. So starting at the lower GI, well, not lower GI system, but the stomach, lower esophagus, your stomach needs to contract in a sequential way. Your lower esophagus has to relax for the substances to come out, and that's mediated by the vagus nerve. The abdominal muscles and diaphragm must contract in a sequential manner, mediated by the spinal nerves, and the upper GI tract, you have to close your glottis, and there's increased salivation mediated by your cranial nerves. So that's a bit of the science for the package set of motions for vomiting. Excellent. So now, this next slide is how we're going to organize our thought process for the differential diagnosis for nausea and vomiting. And if there's kind of one slide that you can take away from all these basic science slides, it would probably be this one. So I think by breaking it down this fashion, not only do you get a bit of understanding of the science, but also can break it down into an easy-to-use cognitive framework by which you can organize your differential diagnosis, but also choose the right antiemetic for that cause, because as we know, antiemetics are receptor neurotransmitter antagonists. So we can kind of link the two, and that'd be very clinically useful. So we'll start with the easy ones, the GI causes that we talked about earlier, gastritis, bowel obstruction, peptic ulcer disease, gastroparesis, things of that nature. They're mostly mediated by serotonin. And as we know, ondansetron is a serotonin antagonist. So that is kind of one big arm of the approach to nausea and vomiting. The second one would be higher brain centers. So as Dr. Stone said, anything inside the CNS system can precipitate nausea and vomiting. I've kind of put two categories here: emotion or pain can elicit this, strange sights or smells, and then I also threw in structural causes, so anything that would increase your ICP, hydrocephalus, masses, bleeding, etc. The structural causes put direct pressure on the nucleus tractus solitarius, mediating the vomiting. The next step, or the next arm, would be the non-GI causes, and you just have to think about pretty much all the other organs in your body that can clinically give you nausea and vomiting. So we're talking about the biliary tract, anything in the peritoneum, renal colic can cause nausea and vomiting. The gonadal organs, testicular, ovarian torsion, or any trauma to the inflammation cause it, and cardiac. You've all seen people with acute coronary syndrome presenting with nausea, vomiting, as well as a bit of chest pain. And these are mediated through what they call splanchnic nerves. So they're just autonomic nerves coming out from all the visceral organs. The neurotransmitter is mostly acetylcholine, but there's a bit of a mix that I won't go into. But just a bit of a framework for the non-GI causes of vomiting. Now, one often that's forgotten is the vestibular causes, so diagnoses such as vertigo, benign proximal positional vertigo, labyrinthitis, and motion sickness. And as I showed you earlier, it was mediated by histamine and acetylcholine. And as we know, Gravol, antihistamine, scopolamine, anticholinergic, antimuscarinic, those were probably your antiemetics of choice for vestibular causes of nausea. The last area that I want to touch on is called the chemoreceptor trigger zone. Now, you may have not heard of this term, but it is another area in the brain that senses both exogenous and endogenous triggers for nausea and vomiting. So, where is the chemoreceptor trigger zone? It is actually very close to the NTS. It's just at the base of the fourth ventricle in the medulla as well. And one interesting fact about the chemoreceptor trigger zone is that it is the one part of the brain that is partially uncovered by glial cells. So it's not covered, it doesn't have a blood-brain barrier to it. And that's on purpose. Its role is to detect kind of toxins or abnormal metabolic features circulating through your blood. It's kind of a sensor for the brain to see if anything in the body's going wrong, and then you can trigger vomiting to expel those toxins potentially. All right. So the endogenous neurotransmitters mediated here are dopamine, histamine, acetylcholine, opiates. That's why you give somebody morphine, they vomit. Opiates would react here. Hormones. So it is postulated that in hyperemesis gravidarum, the elevated levels of beta-HCG are what mediate the reactions here. Various peptides and cannabinoids that Dr. Schapper earlier mentioned would react here. The exogenous substances, various drugs, the ones we classically think about, high levels of acetaminophen, salicylates, digoxin's the classic one, various chemotherapies, bacterial toxins, so people who are septic can often present with nausea and vomiting. That's circulating toxins that affect the NTS, and things like radiation from radiation treatments. Hypercalcemia and uremia are thought of more endogenous, but elevated levels can certainly cause stimulation at the chemoreceptor trigger zone. Okay, and as we know, metoclopramide is a dopamine antagonist, so postulate that could work at this area as well. So just to review very quickly, we have exogenous or endogenous stimuli working at the vomiting center, the NTS. A bit of an approach to differential diagnosis. We have GI causes, gastritis, gastroparesis, etc. Mediated by serotonin. Think ondansetron as a serotonin antagonist. Non-GI causes. I'll think of all the other kind of organs within the body. Vestibular causes, and it is mediated mostly by histamine and acetylcholine. So think antihistaminergics, anticholinergics as your primary antiemetic of choice. And CNS causes, think about kind of the higher centers that we really can't control and then cause increased ICP. And then chemoreceptor trigger zone, which we just covered, so I won't harp on that too much further. Good. So, great. Those are mixed neurotransmitters. A lot of them are mediated by dopamine. Dopamine is the predominant neurotransmitter at the chemoreceptor trigger zone. So think metoclopramide as a dopamine antagonist. All right. We'll stop there. Any questions so far? No, excellent. Okay, so back to the case. Our lovely young gentleman. His labs came back, and they were relatively unremarkable. He did have a bump in his creatinine, 135, nothing to compare it to before. He really had not come to an emerge prior for this. Urea is mildly elevated. I did do a BBG, but everything else was pretty much unremarkable. So what I did for him was very similar to what Dr. Forrestal had mentioned. A bit of an IV bolus, crystalloid, give ondansetron right off the bat, ordered gravel PRN, which the nurse gave because the ondansetron didn't touch his nausea vomiting. I gave him a little bit of dilaudid IV for his epigastric pain, and I reassessed him 2 hours later, and really no gains in terms of any clinical resolution of the symptoms, which was a little frustrating to me. I went to the staff, I forgot who I was working with that day, but I told them, well, we haven't really made any gains. We wish we do next. We didn't get a chest, or we didn't get an X-ray because we didn't think he was parenchymic or he had a bowel obstruction. Well, now do we scan him for epigastric pain? What are we really looking for? Or do we even consider admitting him for to let this play out, or get a GI consult, medicine consult, things like that? So a lot of uncertainty at that point. The staff said, well, why don't you go back and take a bit more of a history, ask him about, any drug use, cannabis use. And so I went back and asked him. So this has actually happened to him about 6 months ago. He had 3 days of nausea vomiting at that point. Didn't come to the ER, resolved spontaneously. I asked him about marijuana use. He said, yeah, I smoke a little bit, 5 to 6 joints per day, every day. So he's a very frequent habitual user. I also asked him about showers, hot showers, which we'll talk about in a second. And he said he was taking 12 hot showers per day. Cannabinoid hyperemesis syndrome looks like, and this might help you diagnose it. Okay. So who to investigate further? So before knowledge of this condition, people were getting everything. So in one case series of 31 patients by Wallace et al. Reported that patients were getting x-rays, CTs, upper scopes, lower scopes, CT head, gastric emptying studies, capsule endoscopy, HIDA scans for biliary or for gallbladder issues, MRCPs. One patient had a neurology consult, 2 patients had a psychiatry consult. So that really suggests that the physicians had no idea what was going on, and they were just casting the net wide, which is definitely appropriate. So these authors of the 98-person case series said that in terms of this should be made as a diagnosis of exclusion, but your workup can be utilized in a case-specific fashion, and in clinical cases where it's very evident that this could be hyperemesis syndrome from cannabinoids, then judicious testing can be utilized. But they didn't mention any specifics or any algorithm. They just kind of threw that out there that maybe when the clinical presentation is very classic, hot showers, cannabis use, nausea, vomiting, relief with cannabis cessation, then perhaps we can stop there and knock out all these scopes and CTs and HIDA scans and whatnot. So excellent. So moving on to our specific ED management. All the case studies have one kind of uniting feature, is that your traditional antiemetics really have minimal effectiveness in this specific cyclical vomiting syndrome. But one agent, like Dr. James mentioned earlier, that we do find of use is Haldol. So I found 2 pieces of evidence for Haldol. First one is a 4-person retrospective case review of people diagnosed with cannabinoid hyperemesis that received Haldol. The dose they actually received in the evidence was 5 milligrams IV, so we have to be very concerned for the side effects of Haldol. Let's ask one of the juniors, when you're giving Haldol, what do you have to look for? PGY 1 or 2? Extrapyramidal symptoms. Anything else?
Cardiac dyskinesia.
Yes. Any cardiac things that you might want to look for? Long QT, excellent. So those are 2 things to consider when you are administering Haldol. But the 4 patients that they gave Haldol to, they had the whole gamut of antiemetics, and then they tried the Haldol, and within 1 hour, symptoms resolved and discharged from ED. So 3 of the patients discharged within 1 hour of Haldol administration. The other one discharged within 2 hours of Haldol administration. And the case study down below, haloperidol, this is sounds like a very problematic patient who had 7 admissions for cannabinoid hyperemesis syndrome, had antiemetics every single time, and then the first time they used Haldol, they had him resolved in the ED and discharged after a short period of observation. So Haldol might be our tool for ED management in this case. So let's go back to a bit of pathophysiology. Why Haldol? We think that perhaps Haldol traditionally is a dopamine antagonist. That's how it fixes the kind of psychosis that was originally intended for. So like metoclopramide, dopamine antagonism seems to be the mechanism of action, so maybe that works. I was just finalizing my rounds, and then Dr. Willett texted me and said, have you heard about this other treatment, capsaicin cream? I'm like, are you talking about like rubbing hot sauce on their bellies? He said, yes, rub hot sauce on their bellies. So this is such recent evidence that they don't actually have a case report published, but it's just presented on a poster at a few toxicological conferences. And one guy had the amazing intuition that these patients are getting relief from hot showers, what's really mediating that? And he thought that the hypothalamic explanation was just a bit far-fetched. He said, why don't we try locally? Why don't we reproduce that by triggering the kind of the local receptors on your skin that reproduces kind of the effect of hot shock. So that would be by utilizing capsaicin, which is the substance found in hot peppers. And in the 2 cases that he used them, they found kind of a 50% reduction in epigastric pain at least, and even a significant resolution of the nausea and vomiting. So I've never ordered capsaicin cream to emerge, but it might be something to consider in the future once these studies roll out. But we want to focus here about what the chronic management is all about. And that's about getting them to stop using cannabis. Now, this can be very difficult. The literature about Dr. Allen, the man who originally coined the phrase, said he found there were 2 different types of patients. Those who really scorned the idea that their vomiting was caused by cannabis use. There's a huge population out there that believe that cannabis is really the cure-all for many medical conditions. And certainly there is evidence supporting that. Antiemetics for glaucoma, things like that, chronic pain. And my patient said, I can't eat if I don't smoke, so I'm just going to keep smoking in order to help me. So their motivation for quitting was like we were on such different levels that I don't think we were very successful in the counseling aspect of getting to stop cannabis use. And then there's the other subset population who says, oh, well, thank you, there's an explanation for this, well, I'm going to try stopping, and these patients are generally more reliable and amenable for follow-up, so might be useful to get the follow-up with a family doctor or even GI to get this thing resolved. So patient education, how do we go about that? I think we have to recognize that, yes, you're right, that cannabis does have medicinal uses in a lot of cases, but in the subset population of people who use cannabis a lot, there's this paradoxical effect. We don't have quite the best medical explanation for it, but we've seen it before, and there is evidence suggesting that if you stop, that perhaps the nausea vomiting cycles will stop as well. So just try to meeting them on their level and explaining that there's this rare kind of condition that might be causing these issues. And there is some evidence for cannabis cessation through drug rehab programs, even cognitive behavioral therapy. But at this point, I think at the Emerge department counseling level, you just want to acknowledge their understanding of what cannabis is, and then also provide your new kind of perspective on it. So what do our local experts think? I emailed Dr. Melanie Bean, who's one of the gastroenterologists at LHSC, and this is kind of a paraphrase of what her response was. So unfortunately, we don't have a lot of successful treatment options. Ultimately, we want to get them off cannabis. On an outpatient basis, they tried using Ativan and ondansetron PO together, and that was more anecdotal evidence suggested by one of the Canadian experts in GM motility. And also, they prescribed kind of ongoing TCAs. I don't know if any of us are going to start prescribing TCAs, but that's just one of the things that they've tried on an outpatient basis with variable success. But really, at the end of it, you have to get them off cannabis use. And she acknowledges that the patients have a really hard time quitting because they really feel that smoking weed helps. So getting them to understand a bit of our process would certainly help. She fully admitted that perhaps the emergency department right now is the expert behind this condition because it's so new and so poorly understood. So I also want to discuss a bit about kind of the public health aspects of cannabis use, because I think we're going to see more and more of this. So I just Googled cannabis use in Canada, and in terms of a national survey, evidently the majority of Canadians support the decriminalization of marijuana. So about 65% of Canadians responded yes, we support decriminalization of cannabis. Here's a very interesting study. So in Colorado, in the year 2000, Colorado kind of amended its constitution and said, we're going to allow for medical marijuana in the state for patients with debilitating conditions. Certainly good. In 2009, the U.S., kind of on a federal level, the U.S. Attorney General said, we're not going to prosecute marijuana users or the trafficking and supplying of marijuana nationwide, So this effectively liberalized the use of marijuana along with its sale in Colorado. So in 2009, there were medical marijuana licenses in the state, 5,051. In 2011, medical marijuana licenses in the state, 118,895. So as a consequence, significant, like more people in the state who are using medical marijuana for whatever condition. So the nice ED docs in Colorado did a study and said, well, now that you've liberalized marijuana, how is it affecting our nurse program? And this is a bit of a cross-section study they did, before and after liberalization, and they saw the number of cannabinoid hyperemesis syndrome cases double in that time. So I think that, Colorado is certainly a microcosm for liberalization of marijuana, but as society in general moves towards that trend, then we're certainly going to see more cannabinoid hyperemesis syndrome. In terms of medicinal marijuana use, there has been some recent changes in the CPSO that actually was going to pass on to Dr. McCauley to give us a bit of information about that.
Marijuana for medical purposes is governed by federal legislation. And it used to be that the way that it worked was that a patient who felt that they needed medical marijuana got a form filled out by a physician that basically acknowledged that they had a number of preset conditions. They would then send that form to Health Canada, and Health Canada would authorize that patient, actually give them an exemption from prosecution. That's what it is, an exemption from prosecution for them to use medical marijuana for medical purposes. And they could obtain that marijuana in a number of different ways, including some patients were allowed to grow their own. 2013, the legislation changed. And the legislation, basically Health Canada is divesting itself from responsibility with respect to the prescription of medical marijuana. So now in order to obtain medical marijuana, you have to have a medical document completed. It can be completed by a physician or a nurse practitioner. Although currently in Ontario anyway, nurse practitioners have not been given the authority to prescribe by their college. So they describe it as a medical document, and a medical document really is the equivalent of a prescription. And the prescription has to have, or the medical document has to have information on it that's similar to what would be on a prescription. So the patient's name, their address, your name, your CPSO number. It's got to have the dose, so the daily amount of marijuana that they're allowed to pre-prescribe and for what duration of time. So it really is just a prescription, and the CPSO, in response to the change in legislation, made a change to the policy on medical marijuana. And essentially it points out that, look, when you are seeing patients for medical marijuana, this is a prescription. For all intents and purposes, it's a prescription, so you have to abide by the prescribing policy. And there are a number of things associated with that, including the fact that you cannot charge a fee for prescribing marijuana, because that's writing a prescription is an insured service. There are also some other things. So, for example, in the policy, they state that quite strongly, in fact, they use must. You must not prescribe to patients under the age of 25, because there is reasonable evidence that for patients under the age of 25, you can have some significant long-term cognitive impairments and psychiatric problems, as well as an increased risk for cannabis use syndrome, which is the DSM-5 classification of substance use disorders. So I think that we're going to, I'm not sure if anyone in our department has been approached by any patients about prescribing medical marijuana for them. Has anyone had that experience yet? I think it's likely to happen. What the patients will do with that prescription then is they then send it to a regulated provider. So there's a regulated grower of marijuana. That's controlled by Health Canada. But they take that prescription, instead of going to a pharmacy, they'll go to a regulated grower and get their marijuana dispensed. Problem is, of course, we don't really know what's in the marijuana. We don't know the concentration of the THC, so it's very difficult to prescribe a dose. I would have no idea how many grams of marijuana that I should be prescribing someone. So the policy just really highlights that you have to know what you're doing. If you're prescribing medical marijuana, you have to know what you're doing. Just like if you're prescribing antidepressants or opiates or antibiotics, you have to have an understanding of the drug and what you're prescribing. So I'll stop there so there's time for discussion. Let Dave finish up the presentation.
So that's really it. I just wanted to go through a bit of the summary points of what we discussed, going back to our nausea vomiting framework five major ways to organize yourself: vestibular, GI tract, higher brain centers, non-GI, and chemoreceptor trigger zone. Just think about your antiemetics that you want to use. If it's GI, you try Nausea first. Vestibular, antihistamines, anticholinergics. Things in the chemoreceptor trigger zone that you might identify would be, you should maybe try a dopaminergic antagonist first, like Maxerin. There's not really much evidence to choose one over the other, but I think on a physiological framework, it does make sense. In terms of the diagnostic criteria, I took out the minor diagnostic criteria. I think we can interpret this from various angles, but if they have a lot of these major diagnostic criteria, the hot showers, the cessation with release of symptoms, relief of symptoms, and the abdominal pains, the vomiting, and heavy cannabis use, that perhaps we can do a bit of a judicious workup. I'm not sure how many of us are consulting GI. Certainly, gastroenterologists have been seeing these patients at a clinic level with various degrees of success, but I think that might be one way to go about things in order for the patient to get ongoing follow-up. And in terms of ED management, we can try using Haldol. I'm not sure if we're ready to commit 5 milligrams. That's just what the literature stated in terms of the IV dose. And then also cannabis cessation counseling, getting them to understand on a different level of what cannabis is doing to their system is the most important thing for treatment and resolution. Okay, thank you very much. That's the end of the presentation.
Did you come across how long it takes to resolve from it? Like if they quit, would you expect them to come back in 2 weeks' time with the same symptoms? Is there
I was wondering, in the case series, they followed up with the 10 patients. They didn't have a follow-up time period. There's been other case reports that mentioned that the cessation is very quick. It's not months or it's not months. It's in the period of days, maybe 1 or 2 weeks. But obviously, there's probably not enough evidence to really pin down a specific time frame. And plus, people have kind of various levels of they have different interactions with the amount of THC they're having, so it's not really a predictable process.
I guess just a comment, it's been a time where I've actually ordered a cannabinoid screening because people were asking, I don't smoke, just to prove that they do at the time. But it would be an indication that, sounds exactly like it, but they're saying I don't smoke, then it comes back positive and you have that discussion. But if they don't, it's maybe a trigger to, something else is going on in GI follow-up. But I don't follow these people up with GI. I think we've got a good cheap drug to help it. It's called hot water. Mm-hmm. So I don't think throwing any tryptophan at them. Yeah. In the emergency department, sure they get them settled, but they often self-medicate and talk shop.
Mm-hmm. I think that's a good point, Matt. And I think that's my approach as well. I ask them if they've been absent from cannabis. I'll do a urine screen and then approach them about that. I think we also have to keep in mind that THC is lipid soluble and it can actually stay in the urine test for up to a couple of weeks.
And I'm talking to people who said I've been on it because I've heard 6 weeks, but I don't know where that came from.
Right. Any other questions or comments?
Bill?
Great.
Just to highlight the initial part of your presentation, the nausea vomiting is such a specific presenting complaint that it's often a trap. It's like the chest pain that comes in, we focus on MI, are they having a heart attack? Nausea vomiting can be anything, right? So oftentimes when I have you guys on, I'll say, what's your differential? Well, the answer is anything. I mean, it's from head to toe, whether it's a brain tumor or a heart attack or a broken limb or anything can cause nausea vomiting. So it's really, really important to keep your differential wide. And most of the time, the history and physical is enough. You don't have to work them up to the hill, but really keep things in mind. I mean, especially in the pediatric age group, we've had some kids come through with multiple visits. The longest multiple visit series is a 2-year-old kid who came in for over a year with nausea and vomiting with absolutely nothing to find. Ended up having a huge posterior fossa tumor. Discovered by GI out of frustration on an admission, they just CT'd the head just because they couldn't figure out any other cause. So be very, very, very careful about nausea, vomiting, and especially the pediatric age group, don't get sucked into the, God, it's gotta be a GI cause.
So just to come back to your point about prescriptions, there are clinics opening up that have referral sheets, and they list off a whole bunch of criteria, fibromyalgia, depression, but they don't often list the age of the patient, which we just learned is a risk factor for CHS. So I just want to bring that up to caution people about that and filling out those referrals, because I think 2 or 3 clinics in town that are opening up.
Any other questions? I want to thank Dave for presenting.